Moving into discussion of therapy techniques. Once you have completed your evaluation, there's a few questions you have to ask yourself. First of all, based on what I've seen, can the patient continue to take food by mouth? Or can the patient go back to taking food by mouth? If they can take food by mouth, as determined by the evaluation, can they do it safely with airway protection? Can they do it in a way that allows them to maintain appropriate nutrition and hydration? And if not, what are your options? Also, consider that the situation and the medical background of different clients, different patients, is going to change your goals and expectations for swallowing therapy. Let's say you have a patient with a degenerative disorder like Alzheimer's that's living in a nursing home that has a certain form of dysphagia. Now, let's say you have an identical patient, except not with a degenerative disorder, but with a traumatic brain injury or stroke, and that patient is not going to be discharged to a nursing home, but is going to go home where he has a healthy and active caregiver. For these two situations, even though they may have the same or very similar swallowing disorder, your actions, your expectations, your therapies that you put into place based on those are going to be very different. For your degenerative patient in the nursing home, you know they're not going to be getting better. And your therapy is going to be more in the realm of compensatory, more in the realm of maintaining quality of life for as long as possible. And you may be also limited by the facility itself and the level of care that the nursing home is able to provide for that client to help the client compensate for their swallowing problem. Contrast that with your stroke patient that's going home with a healthy caregiver. You expect that patient to be able to get better. You're going to be working on restorative strategies with them. You're going to be trying to bring them up as close to normal as is possible, with the understanding that you're probably going to, in the short term, you may be able to put a great many recommendations on the plate of the patient and the caregiver. So you may be telling the caregiver, in order to keep your loved one safe, here is a list of things you need to do for every single swallow. Pureed. For instance, pureed by teaspoon. Cue your loved one to tuck their chin with every teaspoon and swallow hard. That's a lot of intervention, but an active and dedicated caregiver is probably going to be able to facilitate that. There comes a point in a professional facility where just because you have found a way for the client or the patient or the resident to take food successfully by mouth, it doesn't mean that they're going to be able to implement all of your recommendations just due to the logistical limitations of the resources that they have. Although some facilities, like we saw in a video or two ago, have massive amounts of resources to do things like that. So you have to consider what is the prognosis for the patient. You have to consider what the caregiver is able to implement, maybe what the facility is able to implement. You have to consider the benefit to the patient in terms of quality of life. Like, is it going to actually improve their quality of life? And another example is there's a lot of people in a nursing home that may be on a mechanical soft diet. And I could go in and I could give them tons of recommendations. I could give them tons of strategies that would allow them to eat a normal diet. But then they're going to have an LPN or an SLP sitting beside them, cueing them on every bite in the cafeteria, perhaps, which is maybe their primary social outlet. And there's a good chance that last thing that little old lady wants is someone to be hovering over her as she eats, cueing her to do all these things that she may not want to do, just to be able to go from a mechanical soft diet to a normal diet, and have all that impair her social life, what social life there is in the nursing home. So you always want to take the wishes of the client, the patient, the resident into consideration, at least when they're able to give you that. There are some situations, like an acute care hospital, that patient has had a stroke or that patient has had a traumatic brain injury. They don't even know where they are, right? In that case, they really can't give you too much of input on what you need to be doing for them. But once they're able to do that, then you really want to pull that information out. So we can largely divide our therapy strategies into rehab, restoration, and compensatory. But don't think of these as mutually exclusive. Don't think of it as, I have my rehab patients that are going to get better and I'm only going to use rehab strategies. Or I have my degenerative patients that are not going to get better and I'm only going to use my compensatory strategies. Almost all the time you're using some combination of these things. It's not one or the other. The needs of the patient dictates to you what strategies you use, what kinds of strategies you use, and the needs of that patient changes over time. So the strategies that you use will change over time. So for instance, patient has a stroke. The next day, they can't swallow. All right. You have to manage that disorder in the short term. So you're going to put some compensatory strategies into place. You're going to see what consistencies they're able to take. You're going to see what position, posture they need to be in to successfully take that. And then you're going to make sure that they're successfully eating without risk of aspiration. And then you will transition and start working on restoring their ability so that they're not living the rest of their life with thickened liquid on a pureed diet, for instance. And you're going to maximize their recovery, and there comes a point where you have maximized their recovery and maybe you don't anticipate them being able to get any better, at which point you're going to switch back to a compensatory strategy to deal with whatever residual difficulties they're having. So we also think of our therapy strategies in terms of behavioral, which is us somehow changing the behavior of the client to facilitate safe swallow. But in order for that client to change their own, in order for us to change the behavior of the client, that client has to have pretty good intact cognition. If they don't, let's say they have zero memory, zero attention, then it doesn't matter what we do, we're never going to change their behavior because they're never going to remember that they're supposed to be the behavior we're trying to encourage will never generalize because they'll never remember to do it. And which case we have to abandon the attempt to change them behaviorally, and we go to non-behavioral options, which would be like changing the consistency, the presentation of the food, changing something about the environment. And we do lots of things like this for lots of different kinds of clients, but you always want to try to get away from it if the patient has the cognition and the ability to change their behavior, to be able to take a higher level of diet, maybe in a more enhanced, socially enhancing quality of life scenario. But you will get those clients or the residents in a nursing home where they're essentially bedridden. They do not want to leave their room. They have basically very little cognition, very little problem solving, little to no problem solving, memory, attention, but they're able to arouse themselves and eat. This is when that's going to be more appropriate. One of the most important points for you to understand is from this class is on this slide. And that is that both the patient and the family, the caregivers, the nursing staff, whoever it is, they need to understand why you are giving the recommendations that you are giving. They need to understand the importance of your recommendations and the consequences of not following your recommendations. Which is to say, you need to have buy-in from the caregivers, the family of the client, if they're going home, or they are not going to do that. They're not going to follow your recommendations. You need to have buy-in from the nursing staff, wherever you are, so that they understand the importance of your recommendations and you have buy-in from them. The doctors need to understand the importance of your recommendations. And it's not always possible. One of my first years of practicing, I saw a man with Parkinson's disease, referred to acute care for swallowing problems. I did a bedside, I did a modified, I made my recommendations, which would keep him safe, and I sent them home fairly confident that I wasn't going to see him anytime soon. Like a month and a half later, I'm walking down the hallway, I can hear a familiar cough, a familiar hacking cough. Who is that? And I go and I look in, and it's this same man. And his daughter's in there with him. And I go in and I say, "What happened?" Because I know. And she said, "Well, he has pneumonia." And I know that he should not have pneumonia, given my recommendations. And the daughter said, like, "Well, after you told us, what to do and how to handle it, basically the doctor came in and said, don't worry about it. You don't have to do that." And so the patient goes home. The caregiver was relieved that she did not have to put in all this effort that I had suggested she did. But the consequences were that the patient is back in the hospital with aspiration pneumonia. One of the hardest decisions, not necessarily is knowing when to start treatment, because if there's a problem, you pretty much know when to start treatment. But when to stop treatment can be a much harder decision. How much effort do you put in before you're convinced that the patient is going to get any better? I think that you have to look at all the factors, all the information that is available for you to look at, and it gets easier the more experience you get behind you. You have more of a context. You're able to form more make more informed choices based on your past experience. But as usual, I would like to emphasize that always be as hopeful as possible. Always land on the side of giving the patient ample opportunity to improve. And it's much better to err on that side than not giving the patient enough opportunity to improve.